Firstly, thank you for joining and welcome to the latest of VetCT's 12-minute take-home webinars. It's good to see there's quite a few people attending again and still some more joining as we speak. Firstly, just to remind everyone who hasn't already tried it to try the VetCT app. We know that summers are typically busy, and now with the rise in pet numbers and the ping-demic, as we're calling it here in the UK, we know the pressure is on more than ever to ensure your team and clients receive optimum clinical support. Our team of supported specialists are here 24/7 to provide you with the quick answers to clinical queries and guide you through challenging case management. No question is too trivial and no case too straightforward. We know sometimes it's just quick, friendly reassurance you need in the midst of a busy shift. So simply download the VetCT app and get 24/7 access to our team of friendly specialists across all disciplines. While learning on each case, anyone in the UK will also get the added benefit of real-time CPD. If you want more information, you can contact me. My email address is under my face on the screen. Right, on to today's 12-minute webinar. As a reminder, the session itself is being recorded and there will be an opportunity to ask questions at the end. So please do add any of those questions into the Q&A box that you'll see at the bottom of the screen rather than the chat box is useful for us. We'll answer as many as we can in the time and follow up with any others after the webinar. So let me introduce you to Kostas. Kostas is going to be doing our lecture today. Kostas was a senior lecturer in clinical pathology for 25 years. And today's session is a clinical pathology webinar on acute phase proteins. Are they clinically useful? So it's over to you, Kostas.
Thank you very much, David. Good afternoon, everybody, and thank you for joining this webinar on acute phase proteins and trying to cover and answer the question, are they clinically useful? We'll concentrate on dogs and cats. We can have another webinar on horses, which is a topic that we can do in the future. And what I would like to cover in the next 12 minutes or so is just remind ourselves what are the acute phase proteins, how we can measure them, what's the evidence that can answer that question if they are clinically useful or not, the limitations, advantages and disadvantages of using them, and finish off with summarizing a few take-home points from that webinar as well. So we'll start with infection and inflammation, which are the stimuli for the starting of the acute phase response. And these tissue damage that occurs during infection inflammation targets the monocyte and macrophage system, and these cells, they will start secreting different interleukins and cytokines. And interleukin 6, as you can see here with this bold arrow, it is the main product that will go to the liver and the hepatocytes and will trigger the synthesis from the hepatocytes of the acute phase proteins. And you can see here that we have quite a few, and these four are indeed the four major ones that we'll be covering. There are other acute phase proteins that are around, but I will not gonna get into the details for those. And when we're talking about acute phase proteins, we tend to categorize those into two main categories, the major and moderate positive sort of acute phase proteins. And you can see here in the dog, CRP and serum amyloid A are the two main major acute phase proteins, and they're major because the degree of elevation is quite marked. They can actually increase more than 10 times the normal sort of like levels over the period of the inflammatory response. In contrast, on the moderate categories, we have the haptoglobin and the alpha-1 glycoprotein, and these are moderate acute phase proteins because, again, the response to the inflammation is more moderate. They go up to 2 to 10 times the sort of normal sort of like levels. And then you can see in the cat serum amyloid A and alpha-1 glycoprotein are the major acute phase proteins for that species. CRP is not useful at all. And then on the moderate side, haptoglobin, it is the acute phase proteins for the cat. Can go up to 2 times. Occasionally, you can actually get the haptoglobin going a little bit higher. So these are the major and moderate acute phase, positive acute phase proteins. Albumin is considered a negative acute phase protein because actually drops when we have inflammation, and in the cat, actually that's not entirely clear that that's the case, but that's what we consider the albumin. Now, another important point for the acute phase proteins and the major and moderate differentiation is that on top of the degree of elevation, it's important how quickly these proteins are synthesized and circulate after the inflammatory stimulus. And you can see here with the major line, this sort of purpley line, that the major acute proteins that will go up very quickly within 3-4 hours of the inflammation. They can actually peak within 24 hours or so, and then once the stimulus is ceased, then they will start actually dropping, and pretty quickly they will tail off within 3-4 days back to their original levels. Now, the moderate acute phase proteins, as you can see here with this gray sort of like line, they will go up fairly quickly as well, but you can actually see that will take a few days for them to reach the highest concentration they can achieve, and then they will be sticking around for a little bit of time and dropping much slower. And that is the pattern with a moderate acute phase protein response. Now, if we for a moment compare this sort of movement and this sort of elevations and decreases of this acute phase proteins with the white cell count, and I have here a case that was discussed by Sharon and Professor Ono in a meeting. This is an acute pancreatitis case as an example. In this sort of axis here, you can see the white cell count, and then on this sort of axis, we have the CRP concentration. These are the normal levels for CRP, and this is the top normal for the white cell count. And you can see that as we're moving during the days of illness, at the beginning, CRP is quite high, but at the same spot of time, the leukocyte count is fairly much normal. And you can see that it takes some time for the white cell count to actually come above the reference interval. And you can see here that they're actually hovering around for a bit before they start tailing off. By then, the CRP has actually returned back to the normal levels. And it is true that when we compare acute phase proteins with the leukocyte counts, these proteins are much more sensitive to detect inflammation and infection. There are lots of studies that have shown that to us. And also, they can detect activation of chronic infections, where generally the leukocyte counts are not actually doing much when we have an activation of chronic infection. And also, on an analytical point of view, they can actually, as measurements, are much more easy to measure those proteins in the serum than to measure cells in the blood, because cells, they can be more sort of sensitive, and can break down, they can actually change under different sort of storage conditions as well. So how can we measure acute phase proteins? First of all, we measure them in serum, but we can measure them in effusions, we can measure them in synovial fluid, CSF, saliva. It is another body fluid in dogs that we start measuring acute phase proteins. And when we measure them, generally we use serum in plain tubes, But if we want to measure acute phase proteins in heparinized plasma or EDTA or citrate, there are some changes, but overall, the changes are small and of doubtful clinical significance when we interpret acute phase protein results. So we can measure them in other tubes other than the plain ones in serum. Then we can send our samples to external veterinary laboratories where they will use immunoassays, which employ antibodies against parts of the sort of proteins. And in the majority, in many cases, we have specific for dogs and cats immunoassays, but because there is quite a lot of cross-reactivity with the human proteins, we can actually use human assays as well. Or we can actually measure proteins using serum protein electrophoresis. Most of the acute phase proteins migrate to the alpha and beta globulin areas, but these are not as sensitive as the immunoassays for measuring acute phase proteins. The good thing is that we can measure acute phase proteins in our clinic laboratory using point of care tests. And at the moment, the available ones that we have are CRP and serum amyloid A. So I would like to sort of very quickly show you what is available for us for the in-clinic laboratory. There are lots of different kits out there, but these are the ones that have been validated either with analytical based studies or with clinical studies. We have the IDEX Catalyst. There is another machine called Urolizer here, the Teco Medical, some assays from the Life Assays company, and also there's a point strip canine assay came out recently from a company called Usio. So if you have any of these available in your in-clinic lab, then these are good assays, and there are going to be more and more studies coming out for the sort of use of CRP in an in-clinic studies in dogs. In the cat, we have a serum amyloid A available, and this is available only for the Urolizer analyzer, and recently has been validated as well with a study that came out a couple of years ago. So if you have that, then serum amyloid A is available for you for cats as well. Now, are the acute phase proteins clinically useful? We can measure them. I would say that definitely there are lots of advantages, and the major one is that they are extremely highly sensitive for inflammation, systemic inflammation, and as I mentioned before, they increase before the white cell count. So they're more useful than hematology in many cases. But I think that they have an extra usefulness when we have sort of cases where we have a clinical suspicion that there is something wrong with our patient. Although clinically we don't have very many findings, and it's quite possible we might not have any clues on the hematology or the routine biochemistry profiles, but we know that there is something is not right with that patient. And in this particular case, looking for this sort of inflammatory process, acute phase proteins are extremely useful. They're extremely useful in monitoring response to treatment as well. And the principle are these. When the acute phase protein is returned to normal values, that is a good indication that we have a good response, and they do return faster than some other markers of monitoring treatment, like the serum globulins, SP, or the antibody titers that we use to monitor infection. And when they return to normal values, it's a good response to our treatment, and the prognosis is good as well. When after treatment we have no decrease on the acute phase proteins, that may mean that our treatment is not working. We might need to change it, or may mean that we have missed a concurrent inflammatory disease, or this animal may have picked up another disease during the sort of treatment duration that we have this animal on. Obviously, there will be some limitations with acute phase proteins. And as I mentioned already, the specificity, it is low because they will go up to any type and any severity of inflammation. For that reason, we cannot actually give an etiological diagnosis when we have increased acute phase proteins. And also, there are going to be some non-inflammatory stimuli that will give us elevations, false positive SALAS-A elevations, like stress, for example, that can push the acute phase proteins up, vaccination for a period of time, pregnancy with endometrial sort of inflammation and irritation, we can actually have increased acute phase proteins, and intense exercise, we can increase acute phase proteins as well. Treatment with steroids, we know that haptoglobin is going to go up, only haptoglobin, not CRP, and also phenobarbital will push the AGP, the canine AGP up as well. So that is a limitation to bear in mind. I believe that main reason that acute phase proteins that have not been utilized as they should, because in my opinion, the limitations are less than the advantages, but still are a little bit of expensive to actually measure, even with our in-clinic equipment. And when we look specifically at the CRP in dogs, you can actually see here that the CRP will go up to a variety of different inflammatory processes. But I have actually put this table up here to show that as the inflammation increases, then the degree of increase of the CRP goes as well, increases as well. And you can actually see here that with severe inflammation, with septicemia, but also with immune-mediated disorders who have really high CRP values. And when we look at the extremely high CRP values above the 100 mark that we have here, the thing that we have to bear in mind is that they indicate obviously severe systemic disease, and they have shown that the prognosis is a little bit more guarded for this sort of set of diseases that are there. But we cannot actually have an etiological diagnosis. And most importantly, we have to remember that because we have excessive increase on the CRP, very high values, doesn't mean we have a bacterial infection. That doesn't mean that we will be placing willy-nilly and blindly our animal or antibiotic treatment. CRP is extremely useful for staging Leishmania infection, something that we don't see here very often, but in other countries, obviously, it's an endemic problem. And now the staging of Leishmania infection is based a lot on the levels of CRP values in the dogs, symptomatic and asymptomatic dogs. But the point that I want to make here is that we can differentiate steroid-responsive meningitis, arteritis for other neurological diseases with CRP, because we have much higher concentration in the serum and the CSF if we do that. And similarly, if we have a septic polyarthritis or an immune-mediated polyarthritis with high CRP, that can indicate this inflammatory process and not a degenerative joint disease on an intervertebral disc displacement, where the CRP in the majority of cases is normal or is very, very mildly increased. But the other usefulness of CRP is monitoring diseases. We can monitor acute pancreatitis, and as our treatment does a trick and the animal progresses, CRP drops. We can measure treatment of immune-mediated hemolytic anemia. And it is true that can actually follow the increases of the hematocrit as the improvement occurs. But if we actually see that the CRP remains high, although the hematocrit potentially may be a little bit increased, we have to remind ourselves that if the hematocrit is stuck and the CRP is high, then we may actually have thrombosis development, or we may need to change our treatment. We can measure using CRP and monitor the steroid response to meningitis and polyarthritis, And when we have the CRP within normal limits, we can discontinue treatment and we can have recovery. Also, we can measure post-orthopedic surgeries. And generally, the CRP should be actually decreasing within 3-4 days post-op. If after 3-4 days of the operation, we don't have decreases and we have CRP that remain in high levels, then we may have the development of some contamination of the surgical site, or we may have a systemic disease which has been there before or developed during the treatment or post surgery as well. Finally, in a treatment-related mode, I would like to remind that using CRP to monitor the effect of non-steroidals is not particularly useful because non-steroidals, they do not block the production of interleukin-6, which is the major inducer of CRP. So we might actually have an animal that is basically the anti-inflammatory effect of non-steroidals. It is working and doing the job, but the CRP may not be actually coming down as quickly as if we're actually treating it with a treatment that will actually block the IL-6 production. In cats, the information it is less available, but out of the two markers, serum amyloid A and alpha-1 glycoprotein, the serum amyloid A is much more useful because more rapidly responds to a variety of inflammatory infectious conditions and post-surgery. And you can see here different sort of like diseases that we have that response. It is interesting to notice that in all cases of acute pancreatitis in cats, serum amyloid A is increased, so that it's a useful marker there. Also, we found that this serum amyloid A, it is higher in animals, in cats with chlamydia infection, which did not actually show any symptoms, but they do harbor chlamydia organisms in conjunctival swabs. For the alpha-1 glycoprotein, it's the most famous protein because it's a good marker for FIP, and also is raised in lymphoma. And we can measure the AGP to monitor the effect of the adenoplastic treatment for lymphoma. And it is shown that AGP returns to normal when we have cats in remission, although this is not a prognostic marker for survival. And finally, both proteins have been looked in FIV and FELV infected animals that have been treated with interferon omega, and they have actually shown that these are good predictors for immunomodulation, that when this sort of proteins, they actually start to decrease, then we have a good response to the treatment for FELV and FIV. And I'll finish off with the top take-home points. The first one is always use validated assays and tests when you measure CRP and serum amyloid A. It is important to pay attention to the units of the results, especially if they come from different labs, because as you can see here, C-reactive protein is reported as milligrams per liter. Alpha-1 glycoprotein is in micrograms per ml in the dog, but is grams per liter in the cat. So it's quite important when you assess your results, interpret your results, to pay attention to the units. When monitoring animals with acute phase protein, use the same lab or the same in-clinic test. Do not mix and match. There are differences on the results from the different labs and equipment and point of care tests, and use the appropriate reference intervals as your point for normality. Always assess the acute phase protein result, specifically how many times you have increases or decreases of the normal value, in conjunction with the clinical history and your clinical examination findings. The magnitude of increase generally corresponds with the severity of inflammation. But we have to always bear in mind that when the acute phase proteins are within normal limits, that doesn't mean that you don't have a serious disease present. You don't have a serious systemic inflammatory or infectious disease, but you can actually have a localized neoplasm. You can have animals obviously suffering for epilepsy, animals with heart conditions, some other sort of endocrinopathies. So the fact that you have normal result doesn't mean that you should not follow the clinical examination and start looking for other diseases. And finally, it is important, in my opinion, when we are trying to establish clinically healthy animals to include acute phase protein measurement there, especially when you're trying to select your blood donors, or you are involved in a clinical study where you're going to have some clinically healthy animals involved there. It is good to measure acute phase proteins in your profile to make sure that these animals indeed don't have any inflammatory conditions present. And with that, I would like to thank you for your attention and happy to answer any questions if you have any. Thank you.
Hi, Kostas. I see we have a question for you. The question is there any need for a special protocol to get the blood sample?
If there's any need for a special protocol to for the blood sample, no. The acute phase proteins are proteins like albumin, like any other protein in the blood. We follow exactly the same procedures as if we're going to measure anything in the blood, liver enzymes, urea, creatinine, SDMA, CRP, serum amyloid A is exactly the same. There is, just give me the opportunity, there are some changes if you have a sample that is hemolyzed or potentially it is icteric, but generally the CRP and serum amyloid A, and concentrate on those because these are the two ones, the main ones in the dog and the cat that we have access in our lab as well, in our clinic lab. Generally, the changes are very minor, and the message is that they do not actually alter significant the interpretation of our result in a clinical content. If you have a slightly hemolyzed sample or it takes some.
Great. And one other question: does body condition influence it?
If the body condition has an effect on the CRP, in general terms, it does. And I will go and I will use both ends of obese dogs and cats. Specifically, the work is done with dogs and also emaciated or thin animals. But again, these sort of changes are not important enough to actually alter your interpretation. So when you're actually using your reference values to interpret the number that you have received, and that number is 2 times or 3 times, so 1.5 times above your top normal, that interpretation can be still used when you have an animal which is obese or slightly thin. So the changes are not severe enough to actually change your interpretation.
Perfect. I think we've got one more question. If neoplasia can cause necrosis and inflammation, will it raise APP? More specifically, can APP be used to differentiate inflammation and neoplasia when looking at granulocytic leukemia? Excuse my pronunciation there.
I missed the second bit, David. Is it? Shall I actually
You
read?
see it on in the Q&A, you can see it there, but it says
Yeah,
more
let
specifically.
me go and do
More
the.
specifically, can APP be used to differentiate inflammation and neoplasia when looking at granulocytic leukemia?
Okay, can artificial be used to differentiate inflammation, neoplasia, and we were looking. Okay, so if we have an animal that has sort of excessive increase or marked increase on the white cell count, and that potentially can indicate that we have leukemia because we have really high numbers. Can we use in the dog the CRP or in the cat the serum amyloid A to actually do the differentiation? And the answer to this question is no. We cannot use the CRP because marked systemic inflammation, but also neoplasias can actually both give you increase on the CRP, and there is not a cutoff where you can actually say, okay, the CRP is above that. That means that we have an inflammatory response, and because the CRP is not as high as that, that means that we have a leukemia. So in order to go along with this type of differentiations, we need to actually look of other findings. And the things that obviously are going to be important is to look for the presence of a left shift, for the presence of toxic, potentially neutrophils. If we are having an increase on the white cell count, that they're going to be sort of more indicative of a inflammatory process. The presence of circulating abnormal sort of cells potentially that can give us a little bit of a clue for leukemia from that respect. So we need to actually follow the other sort of like findings that we can have in our investigation to try and get closer to this differentiation, because CRP is not going to be specific enough to actually make that differentiation.
Perfect, thank you. I think that's all the questions, and that's about right in terms of timing as well. So just a quick thank you, Kostas, for that, and thanks everyone for attending. Next week we do have another session on Wednesday 28th, slightly later at 7 p.m. UK time. This will be with Dr. Copper Aitken Palmer on an exotics session on guinea pigs. So please do register ahead. The recording of this will be available on our website and also through our YouTube channel. And we look forward to seeing you in the next one.